Welcome everybody. We are back to another session of the CIC study series. This is series 5 on infection prevention practices, brought to you by Barbara from the APIC Kern Rivers chapter. So we will begin by talking about transmission, how our microorganisms and diseases pass through the healthcare setting. So, of course, being infection preventionists, we're first going to talk about contamination through hands. The greatest risk of poor hand hygiene is with artificial nails. Healthcare providers with artificial nails are more likely to have gram-negative bacteria than those without. And hand hygiene with alcohol-based hand rub is the preferred method, except for when handling with C. diff patients, according to how your policy reads on that. We measure compliance through either the use of an electronic system or through conducting observations and monitoring adherence to the artificial nail policies that we have in place. So to carry on with the topic of transmission, the transmission of pathogens in the healthcare environment generally occurs through either the air, a fomite, or contact, not through a vector. So a vector is an organism, typically a biting insect or tick, that transmits disease from one animal to another. So a vector, like a mosquito, transmits malaria. So we may have patients with malaria in our healthcare facilities, but they did not acquire it there. The decolonization of MRSA is discouraged except for before certain surgeries. Routine environmental cultures are also discouraged. The transportation of a patient on droplet or airborne should include the patient wearing a surgical mask. Staff assisting in a bronchoscopy to rule out confirmed or suspect TB must wear some type of enhanced respiratory device. Respiratory hand hygiene also will include offering a surgical mask to a patient, discarding used masks and tissues, posting signs in public areas to advise them of these practices, and covering the mouth and nose when sneezing or coughing in the crook of the elbow or into tissue, but not into hands. So we want to educate with that as well. How diseases are transmitted in the healthcare environment is usually either directly or indirectly. So if it's direct transmission, then the pathogen is traveling from person to person without an intermediary. Whereas if it's indirect, then it is spread when an infected person coughs or sneezes and sends infectious droplets into the air, and this is what we are concerned about with contaminated equipment. Transmission can be determined by looking at 4 clinical variables: the inoculum of the bacteria, meaning how much bacteria there is, the virulence, or the ability to cause the disease that the bacteria has, variance in the environment, meaning differences in temperature and humidity, and other environmental factors such as food sources that can affect the viability of the organism, and the efficiency of host defenses. So how likely is the person to get sick based on their comorbidities? We also have to use safe injection practices, like using single-dose vials, never using a single-dose vial on multiple patients. This is key because they will lack antimicrobial properties, and improper use can lead to contamination if you do have that practice. You do not want to enter medications with used needles, but with new needles, even on the same patient. Use needles and syringes and eye drops only for one patient. And use fluid infusion and administration steps for one patient only, and dispose of after use. So handling of contaminated items, this is always a big issue as we're being surveyed by various agencies. A small amount of blood and blood products, dried on dressings, or other disposable items represents an insignificant hazard and thus do not require disposal as biohazard. But bulk blood tin, suction fluids, secretions are considered infectious, and they must be treated as biohazard. Privacy curtains should be changed on a routine schedule and whenever is soiled, or perhaps when a patient is on contact and that patient is discharged or transferred. IV catheter stylets have the highest risk of blood-borne transmission because they are hollow-bore needles that can be filled with blood, and therefore that blood can easily be transmitted to a healthcare provider. ICU and other units where immunocompromised patients should not have a flower in a vase, fresh fruit, or a fish tank. You should use latex-free balloons in these environments. Patients on contact isolation may ambulate in the hallways provided the patient washes their hands and wears a clean gown before leaving to ambulate. And of course, then the whole idea here is that they are able to control their excretions and secretions causing them to be on contact. So if it's a draining wound, then that wound can be dressed and the drainage contained during the time that the patient is ambulating. Clothing that is contaminated by a large volume of blood or other bodily fluid should be removed carefully. You might have to cut it off, and then you dispose of it in the biohazard containers. Droplet transmission often occurs through coughing, sneezing, and so regulations. We have to base all of our educational programs on standards issued by national or international authoritative sources. So this is really key because we can't just use one article and make our practice based on that. It has to be based on recognized standards. Another regulation is that multi-dose vials have to be disposed of after 28 days. The U.S. federal agencies having published regulations pertaining to infection and medical or regulated waste are the EPA, OSHA, and DOT. Patient care supplies must not be stored in cardboard boxes, and the reason is because they are likely to harbor dust, bacteria, and insects. So anything corrugated is a no. The FDA, under the Department of Health and Human Services, develops, implements, and monitors the standards for drugs, biologics, food, blood, and medical devices. And the blood bank is under the authority of the FDA. The Safe Medical Device Act is also under its authority. Further regulations that infection preventionists need to be aware of is that there is an OSHA requirement for laundry, and that is that the employer must launder the garments of an employee that have become contaminated at work, and they should be bagged at the point of use before being transported to the laundry services. OSHA has further regulatory handling over facility design, construction, renovation, and over the isolation of TB cases in a AIIR, Airborne Infection Isolation Room. Specifically, these requirements are that the room must be negative pressure, and I just always remember that anything contaminated or dirty is always negative, so like a soiled utility room must always have negative pressure. An airborne isolation room, negative pressure, that sort of thing. You must have 6 to 12 air exchanges with direct exhaust to the outside. When these rooms are in use, they must be monitored daily. And of course, the door should be kept closed. And there should only be one patient in the room. Antimicrobial stewardship programs are a must for hospitals operating within the United States and should really be part of any infection prevention program. Facilities can perform an antibiotic timeout after the availability of culture results so that we make sure we're treating that patient appropriately. Strategies to curb resistance includes formulary restrictions, automatic stop orders, and antimicrobial cycling. Patients may be treated empirically, meaning before a culture is available, based on symptomology with a broad spectrum, and then therapy can be adjusted after results become available. Antimicrobial stewardship exists to ensure that the right therapy is given to the right patient with the right dose at the right duration. An antimicrobial stewardship program should include the infection preventionist, pharmacist, and an infectious disease physician. There are a few different organisms that are listed as urgent concern by the CDC for drug resistance, namely Neisseria gonorrhea and C. diff. It is not always necessary to maintain the antimicrobial concentration in the body above the MIC if they are not time-dependent drugs. Antibiograms provide necessary information on antimicrobial usage and resistance patterns in the community. They show the percentage of isolates that were resistant to each antimicrobial. There should be at least 30 diagnostic isolates on the antibiogram. And this should be prepared by the lab. Let's talk about vaccines now. The storage of vaccines is very important as they can become non-effective if stored improperly. Vaccines that require refrigeration should be stored between 35 to 46 Fahrenheit, and we should monitor the temperature of storage units with external monitoring devices. We have to have consents to be immunized, and it can include a personal belief exemption, and there can be medical exemptions as well. Vaccines are available for a number of diseases, but here specifically diphtheria, varicella, and pertussis, but not CMV cytomegalovirus. Vaccination is also the primary way to prevent influenza, and a recent vaccination for smallpox does not require special isolation. Continuing with vaccines, the recommended vaccines for healthcare providers, we've mentioned this previously, but as a refresher, is the MMR vaccine, hepatitis B, this comes in a series. If exposure before the series is complete, then we give immunoglobulin along with the vaccine for post-exposure prophylaxis. Influenza. For healthcare providers who do not want the vaccine, they can be told that the immune response to the vaccine may cause symptoms, but they cannot actually get the flu from the vaccine. This can help boost your compliance towards the 90% goal by 2020. And we have to get our flu vaccination annually due to antigenic drift of the virus. We have to prioritize immunizations to employees working with immunocompromised patients in the event of a shortage. Further regulations talk about some required documents for infection prevention, beginning with the annual infection prevention risk assessment, which is to determine goals and the objectives for the following year based on the institution's strategic goals and data and finding from the previous year. You have to identify your community's risk based on its location and population and those that are serviced by the facility, as well as the educational needs. Another important document is the infection prevention plan, which includes clearly stated goals and objectives and educational needs as well, and uses specific units of measurement and timeframes. A little bit about employee health, as infection prevention has a collaborative relationship with employee health. A lot of times in smaller facilities, infection preventionists also serve as the employee health nurse. Employee health does track needle stick injuries. Immediately after a needle stick, then if the person is known HIV, the healthcare worker should wash and then be treated with a multi-drug post-exposure prophylaxis, PEP. Healthcare personnel, when we're talking about vaccinations and tracking injuries, means all persons, paid and unpaid, working in the facility. Healthcare personnel may be able to claim workers' comp for occupational exposure to infectious diseases based on the policies your institution has in place. So now we will turn the page and talk about HAIs, beginning with, you could probably guess it by the picture, surgical site infections, or SSIs. The management of the SSI must include, or may include, opening and draining the incision, debridement, antimicrobial management, and managing the open wound. The definition includes for superficial SSI that the infection occurs within 30 days of the original surgery and that the affected tissue is either the skin or subcutaneous tissue, plus one of the following: purulent drainage, organisms identified from the superficial layers, the wound is deliberately opened, and the patient has pain, swelling, redness, or heat. And also diagnosis by a surgeon does count for the superficial SSI. Procedures requiring 90-day surveillance. Well, first of all, for 90-day surveillance must be infected at the deep or organ space level. So you cannot have a superficial infection on day 31. On day 31, it does not count for any kind of infection if it's superficial. So if it doesn't involve the deep or organ space level on day 31 or after, then it is not an SSI. You can report provider-specific rates to your surgeons as a way for collaboration and open communication. Elective procedures do lower the risk for developing an SSI. Is prepped and ready. Furthering with our discussion on HAIs is CODI. The NHSN criteria for a symptomatic urinary tract infection is that the foli is in place for greater than 2 calendar days. There's more than 100,000 CFUs of bacteria. And then they've got a symptom such as fever, suprapubic pain or tenderness, or coastal vertebral angle pain. Common causes of non-catheter associated UTIs, bubble bath, prolonged soaking in a tub, and excessive. Continuing on, we'll talk about CLABSI. The NHSN criteria for CLABSI is that the central line is in place for greater than 2 calendar days. There are pathogens grown from one or more specimens. Maximum sterile barrier precautions for central line insertion includes sterile surgical gown and gloves, mask, cap, and sterile drape. We should only replace. Continuing on with CLABSI, infections of short-term access site, for example, those in place less than 10 days, like a peripheral IV, non-cuff, non-tunnel, central venous catheter, is due to a lot of times the percutaneous transmission during insertion, extraluminal transmission, contamination of IV fluids. Infection of a long-term access site is often due to contamination of the catheter hub, luminal fluid. Short-term central lines that have the highest risk of infection are femorals and jugulars. Dialysis access infection prevention. Use an AV graft or fistula. Use a tunneled cuffed catheter. Don't use a femoral for more than 5 days. And to collect blood, always use 2 different peripheral sites 15 minutes apart. And of course, make sure to collect enough volume of blood for accurate testing. And we will also be talking about VAP, ventilator-associated pneumonia, and ventilator-associated events, which we often try to prevent through oral pharyngeal cleansing and decontamination with an aseptic agent, orotracheal intubation, and the head of the bed being. MDRO risk increases in patients with recent antimicrobial therapy, hospitalization, immunocompromised state, we can ensure the quality of blood cultures by collecting prior to administration of an antimicrobial. Special populations, you guessed it, dialysis. Any supplies that come in contact with the machine should be discarded as those items cannot be cleaned. Hepatitis B, so if the patient has hepatitis B, then we need to separate the machine and put them in a separate room. Dialysis water must have total viable microbial counts and an endotoxin count as well reported to infection prevention. Patients are at increased risk of staph infection if they have poor hygiene. Thus, patients should be taught to wash their access site with soap and water daily and Carrying on with special populations, body piercings and tattooing, often difficult to monitor due to the lack of training by inspectors. Ebola requires droplet and contact. If a breach happens in the PPE during patient care, then the healthcare provider must go to a doffing area to assess the damage. If we have an unknown agent from a bioterrorism attack, then we would go into contact and airborne for that patient. In the kitchen, we will prioritize food usage during prolonged electrical outages by using food in unpowered refrigerators first. And food should be stored in such a way to prevent cross-contamination. Thus, raw meats should be stored under produce, not the other way around. Dietary workers are allowed to wear a plain wedding band, but we want to minimize the risk of harboring pathogens in the rings. Dietary workers should use non-absorbent cutting boards, again to reduce the bacterial population from spreading from one food to another. Food should be stored at least 6 inches off the floor. And lastly, with our special populations is our service animals. So you need to have guidelines, some type of a policy in place. You can require that the animals be bathed within 24 hours of the visit. May require a vest or clothing to control the release of the dander into the air. You can require that the animal be healthy and current on immunizations. And the handlers may be asked to ensure that the animals do not lick or contact a patient's open wound or devices. Animals may be on a patient's bed if a barrier is used, like a sheet or some chucks. Animals are to be kept on a leash, and hand hygiene should be performed after contact with the animal. So here we are. We have our questions. At the end of every chapter, we have these questions, and this is where you get to test your knowledge and see how well you have learned the material that is being presented. Again, we are using the 6th edition certification study guide put out by APIC, and there are more resources available there on the website. Thank you, and good luck studying, everyone.